Welcome back to another episode of Coffee with Coker. My name's Mark Rybolt, and I'm the host. If you don't know, if you're not familiar, or if this is your first time listening, Coffee with Coker is a healthcare business podcast. It's published by the Coker Group, and we talk about solutions that help healthcare organizations effectively navigate the changing healthcare industry. And so we're back with another episode, and this one has a guest that we've had on at least once before, and certainly one that you'll hear more of. But he's new to the Coker team. His name is Brandt Jewell. He's a senior vice president with Coker, and he runs what we call our physician services group. And so it includes a lot of different things, but specifically what we're talking about today is improving patient access. And Brandt actually recently developed a presentation on this topic and has also been writing a good bit on this. So I know you'll see more content coming out on this subject, but the discussion today with Brandt really gave us a good opportunity to dive into this topic around patient access, which, as you can imagine, is a big one, but it also entails a lot. And so we talked about different components of patient access, particularly a lot of the challenges that whether it's a practice or it's a hospital-owned physician network or whatever it may be, some of the challenges they face in today's marketplace as it relates to patient access. And then we talked about, some ways that groups can look to improve, specifically on patient access and what it means for creating value, improving quality, enhancing either your services, perhaps expanding your services, and ultimately, some sort of value back to whether it's the physicians or the health system or whatever it may be. So it was a really good and timely discussion, as this is something we get a lot of feedback on from our clients, and of course Brandt has a lot of experience in this space, so we wanted to spend a little time talking about it, and I know we'll talk about it more in the future. So I hope you enjoy. Also, just as a continued reminder, feel free to check us out in terms of not only this episode of the podcast, but every episode of the Coffee with Coker podcast. You can find us at coffeewithcoker.com. Or you can go to cokergroup.com and find us there. We encourage all of you to subscribe, which you can do on all of the standard podcast forums. And then again, you can listen to all the episodes directly on that website, coffeewithcoker.com. And also, we like to encourage you guys to submit feedback. If you have questions or comments on anything we've talked about on a previous episode, or if you'd like to get more information on any other topics that maybe we haven't covered yet, or a topic you'd like us to drill down into more detail on, we love to get that feedback. And we're going to actually be having another episode coming out probably where we address some of those questions and some of that feedback. And it will get covered. So we will make sure to respond and perhaps address it on a future episode as well. So again, we encourage you guys to follow us and subscribe and send us your recommendations. Otherwise, I hope you enjoy this episode on patient access with Brandt Jewell. Today, as we mentioned in the intro, we are joined by another guest who has been on the podcast before, but being kind of new still to Coker, we feel a lot of opportunity to get him involved in some of these discussions, and it's been exciting. So we wanted to bring him back. So anyway, as we mentioned, we have Brandt Jewell back with us, and so today what he's going to be talking about is something that he has a lot of experience with, and it's something that's obviously very relevant to our audience and to the clients we work with. And so we thought it would make sense to have a discussion about it. And again, as we mentioned, there's also going to be additional content coming out here in the future on this subject. So what we're talking about today is patient access, specifically improving patient access. And so, by the way, Brandt, welcome back.
Thanks. Glad to be here.
Yeah. So I guess patient access is one of those terms that I feel like could be fairly broad or somewhat ambiguous in terms of depending on the perspective someone may come from, how they interpret that. So I guess as we start out, just tell us, what do you mean? What is patient access, and what are you referring to when you talk about improving patient access?
Yeah, I think that the audience there is relevant to the definition. And so for a patient, I consider the access to be how easily and efficiently I can access the care that I want. And maybe that's not always the care I need, but the care I want in a timely manner. If I'm a provider organization, whether that's a practice or a health system, then I would define it more as how we as a system or a practice manage all the touch points we have with patients in order to schedule and coordinate the services that we're going to provide to them, all in an effort to minimize the wait and disruption to the patient. We have to put those puzzle pieces together.
It's an interesting distinction you made there just in your first comment, just the difference sometimes that is between what the patient wants or may think they need versus what they actually need. And so there is I have to think here that when you're talking about patient access, there's an element of that factor in convenience, which is a major factor, and especially nowadays, I think, in a world of more and more consumerism, consumer-driven mindset, even within healthcare. But there's also a clinical component there too. And so there's, should be ideally a reason why a clinician, a practice does what they do as far as managing patient care. Sometimes doesn't translate into the most convenient, or it's not obvious that it's the most convenient for the actual patient. So it seems like there has to be a connection there to make that.
Right. And I think patient access tends to be nebulous and confusing to all parties, right? So whether you're the CEO who gets an angry call from a friend or a board member because their mom or brother or sister can't get into the doctor that they want to see and can't get a call back, or you're the patient on the other end, or the provider who's frustrated because you don't realize why your patients can't get in to see you. You think you're available, or you're sitting idle for an hour during the day and don't understand why someone's there. And so I think taking away that ambiguity and trying to just lay some ground rules within the practice, at the nuts and bolts operations level, helps eliminate the confusion. The patients can feel that when the practice is confused, when the nurse or the person they talk to on the phone can't help them, then that just builds this frustration around patient access. And then it boils up, to C-suites all over the country.
Right.
And we hear from that all the time.
Yeah. So I got to think it is, man. It has to be a constant thing. I can't imagine any one organization has been able to truly perfect this, or if they ever will. And no organization is immune to potentially having issues around patient access. Whether you are the largest health system in a particular market, all the way down to the small practice. Do you agree, or do you see kind of different levels of patient access issues depending on the size and scope or scale?
Yeah, absolutely. Generally, the problem with patient access is we label it one thing, but the solutions or the actual issues within every organization are going to be very different. And so for your large integrated health systems with lots of centralized functions, where maybe a call center with schedulers are the only ones touching provider schedules and things are getting kicked around, and large EHR buckets versus a single doc shop where everyone can yell down the hallway to figure out when the next available appointment is. They both have their own issues and complexities. Patient complexity and populations in different service areas can also really impact patient access with regard to no-shows and cancellations. So there's a lot of variability, and there's no silver bullet for addressing patient access, whether large or small, academic or for-profit or not-for-profit. So the important thing, I think, and kind of a theme for what we'll discuss today, is getting your arms around your patient access issues to the extent possible, using data to inform your patient access issues and letting it be a team effort. Putting data in front of not just your senior level folks or your providers, but in front of your frontline managers and then your staff, and providing targets that people understand. I want to drive down this no-show rate. I'm going to make that extra call or double book this appointment because I know this person and I know they're not coming in, that kind of thing. The problem with patient access solutions happens and actually moving the needle is that it's a daily blocking and tackling, which you said. And so you can put in place all the rules and regulations and protocols you want to for your organization, but at the end of the day, this is happening in the trenches with your frontline soldiers and employees. And so you've got to have that stomach for making it a priority every day. And a lot of organizations we work with work it into their morning huddles between their front or back office staff just to make sure that everyone's focused on filling the slots for the day and addressing any holes.
Yeah. We'll definitely get to some of the kind of solutions and alternatives, I guess, that we can kind of dig into deeper in terms of improving patient access. I guess before we do that, let's back up and talk about what are some of the challenges that most of your practices or even your health systems face around patient access?
I think there are a lot, and we'll probably miss a few today, but some of the more significant ones that we see, especially in today's environment, and this is a compounding issue, not just for patient access, but for a lot of operational items, but this culture of independent practices. A lot of health systems, big and small, have grown and acquired physician practices over the years. Maybe even they acquired them, got rid of them, and have reacquired some of them in the recent years. But there are oftentimes promises made of allowing practices to continue to operate independently. You get to keep your own protocols and rules, and we're not going to come in and make you do it the way that we do it. And what you end up with is what we call a federation of practices. And so as long as things are going really well at each one of those places, then you can exist like that to a point. But then once you reach a certain critical mass, you start to think, well, do we really need a phone room in each of these clinics, or could half the amount of people do this in a single place if we routed it that way? And you can try to benefit from economies of scale. So as we see groups start to do that, there's usually a big hang up. And then once you're doing that, any practice you bring in is going to impact the way that you manage that schedule. And so the culture around that, I think, puts up a huge barrier in many cases. And then that drives how you communicate and engage your providers around this process. If providers come into your organization thinking, I don't have to, nothing's going to change for me, I'm going to do it this way, or I've been here for 30 years and therefore I'm not going to change and I'm not going to do it this way,
sure, then
you're setting yourself up for variability. And we'll continue to have another theme here about variability in both scheduling types, visit links, appointment types, and the algorithms and rules around managing those schedules breeds confusion, and it makes it harder for anyone who's not intimate with that practice to be helpful. So the variability and the provider engagement on the front end, getting providers involved, is one of our key focuses when we work with clients on this, because if you've ever tried to go in and change a provider's schedule against their will, then I'm sure you've been unsuccessful with that, as I have before as well. So this is one of those sensitive areas where we're not talking about centralizing a billing office or doing something behind the scenes that doesn't affect provider. You're talking about every day, how do I feel when I come into the office and when I leave? And so it's very personal. Patient communication piece is also a key area of focus, and setting those expectations. Every organization has a precedent with their patients, good or bad, on how they handle this. And so to drive, for example, patients towards a portal where they can self-schedule online sounds like a really efficient way to do things if you have the tools, but that may not be attractive to your patient population, or you may have established a culture where patients know they don't need to call and let you know they're not showing up today because they do it all the time. There's no penalty for no showing. There's no penalty for canceling 10 minutes before your visit. And there doesn't also have to be a penalty, but establishing a culture around your respect for the provider visit and their respect for the provider visit is important. And oftentimes we see a breakdown there when we start to make changes here. The technology and data is a key piece I alluded to earlier. Just having the tools and some sort of metrics, even if they're basic, and in some cases, even if they're manual, to be able to say, here's what we want to accomplish. These data elements inform together how we're doing, and we're going to target being better in these areas. It's really hard and frustrating for any type of system with all these different players involved to understand where they sit. Every patient complaint can't sound the alarm bells because they couldn't get in or because they waited too long on the phone. But each of those matters, and at a certain point, you have enough data and information to think, we probably do have a problem with our phones, or maybe people really can't get in for 6 months to see their primary care doctor. So I think using data to actually understand the reality of the situation and then cleaning that data. A lot of places we go, you could have front office receptionists sitting next to each other who all handle a no-show or a cancellation or a reschedule differently. So therefore your data in your system is going to be flawed, and you get kind of garbage in, garbage out. Sure. We'll go to places that say, we have, a 3% no-show rate. And then when we realize that they don't no-show a patient if they call and cancel, even if it's 10 minutes before or the day before, it just everything's reschedules. But you're still missing a visit slot at the end of the day. That type of variability, again, drives confusion, and it makes providers and management think it's worse or better depending on the situation.
Well, the thing I like about the data piece is as we've come into a world and are continuing to migrate into a world of significant growing amounts of data available, particularly in the health system or medical practice space. A lot of solutions out there, a lot of data behind it. One of the big challenges we talk about all the time as it relates to data and analytics is how to make it meaningful and do something with it. Patient access is one of those things I feel like it's the low-hanging fruit, or potentially could be the low-hanging fruit of making that data meaningful and actually getting either, answers out of that data or developing solutions as a result of the information derived from such data. That's something you can go in and you can look at and almost pinpoint, and you can implement changes. Not always easy, but at least you can identify where change is needed and make some adjustments.
And it's tangible. Sometimes we get data that requires a lot of assumptions to take action on. And with this, you can take the data, understand the implications, and then really put in place some actionable steps to address it. And I think people get overwhelmed by the multiple areas in which they could focus,
right?
And then they kind of get paralyzed, and that could be paralyzed without data or paralyzed with data,
right?
Trying to figure out what to do.
Yeah, that's a good point. The other thing here, this is a little bit of a tangent, but I just was thinking about it. When you talk about technology, it's not just the solutions on the internal side to make processes more efficient, but it's also it seems like we're seeing more external facing solutions that play into, whether you want to call it telehealth or virtual care, that type of thing, that helps or potentially could help and bridge some of that gap as it relates to patient access. Specifically, I know there's a system here locally where that has a program with their urgent care facilities. So if you have your kid, for instance, is sore throat or something like that, and they can do kind of a virtual visit with one of the physicians, and they're not having to go wait for an hour in the urgent care center, or certainly not the ER and traffic and all that stuff. At least kind of get initial observation on them, and then if they do need to come in, they're already in the queue, they're already in the system, they've already been at least maybe have an initial chart worked up, things like that. So I think that's another thing that, particularly on the hospital side, where we're seeing the technology potentially coming in, bridging the gap.
Yep. And more, you mentioned this consumer-facing environment that we've entered into, and this on-demand consumerism. That's becoming a competitive play for health systems, especially in larger markets like Atlanta or larger cities and more urban areas where there's a lot of competition.
Sure.
And there's a lot of potential access to care. When we may even be oversupplied, quite frankly, in a lot of those places. And so what makes a patient come to me instead of you? And by and large, it's going to be, all the doctors have apparent quality, and who can I get into the most easily and the most conveniently with the best customer service?
Yeah.
And so, this increasingly is a market share play and strategy play as much as it is a basic operational blocking and tackling
that's
play.
A good point. Really good point. So talked about some of the challenges. What do you see are the key barriers here as we think about patient access?
Yeah, so when access is restricted, we talked about some of the challenges coming out of the gates, but I think that the things that cause access to continually be an issue is this unwillingness to give up operating standards. And whether that's operating standards that have been in place for a long time with this organization, my private practice's operating protocols and how we handled things before we joined the organization, all of that, again, leads to variability and ends up feeding this black box of patient scheduling management and access, and no one can tell what the real problem is because everyone has a different reason for it. One of the big things that we work with clients on is around the scheduling templates, and both from visit lengths to appointment types to we call them scheduling algorithms, where you can put people when. We work with a lot of organizations that you'd be surprised at, the sophistication of the organization, where we still have big rules and provider schedules that, we won't see blonde patients on Tuesdays in months that end in Y type rules. And we've looked at schedules where we realize at the end of the month, this provider can only see 2 new patients based on their available time in clinic and the restrictions they have on their schedule. And they may not even realize that, because every time a patient gets angry or a provider comes in and their day's blown up because someone put a patient on their schedule they didn't know about, then they say, add this to my list of things. And it just kind of evolves over time. We end up with an insurmountable list of tasks to put a patient on a schedule. And we can't blame the providers in all these cases, because there's a somewhat, like I said, it's personal to them. And then I don't blame them for being defensive about this being their time and wanting some control over their schedule.
Sure.
What we try to help convey is that the best way for you to really control your schedule is to have the people who support you make the right decisions on your behalf. But if every time a patient needs to get added, it's getting floated to the provider who's in the room with the patient already, then you're going to frustrate your patients, and you're going to end up with the runaround, and you're going to end up with empty slots. And that, again, is frustrating.
Well, most of the providers I've worked with and come across, they want to work, and they work hard, but they do need that balance and understanding what does balance mean for Dr. A versus nurse practitioner B versus, physician assistant C, or whatever it may be. That can vary. And so understanding what that balance looks like, others can manage that much more efficiently.
Yep. And in order for others, especially in a centralized environment where people aren't intimate with the practice, maybe haven't even met this physician, for them to be able to effectively manage the schedule, it needs to be simpler. So for a family practice, for example, with 10 docs, we can't have 13 different visit lengths for physicals. We can't have 100 different visit types, because everyone has a different name for what they call these visits. And then you layer on top of that all these different rules and regulations by provider, and it would take 5 minutes to just sort through who you could book with and when, much less what the right visit is. So I think that's the control give that you ask for from providers. You got to give up some control and come to consensus as a group of providers on how you're going to handle these things. And then we, as the administrative side of the house, are going to make sure that we do everything we can to stay within these guidelines, because we know if we play within this, we can take initiative and put a patient in a slot after, in real time, as opposed to having to mess it up. So I think that's where the providers want to be busy, they want to be efficient, but to do that, sometimes they have to give up some control or some of the autonomy of the schedule and play with the group level instead of as an individual.
Which I have to think that would take you then to talking about the people themselves and the staff, the quality and resources they have, their kind of charges in terms of what they're able to do, what they're capable of doing. All probably comes down to people at some point in this process.
Yep. Establishing roles and responsibilities is key with really any operational change. And there's usually confusion around this, whether it's a private practice where, I have my nurse and she's the only person who can really make any decisions or touch any of my schedules, regardless of who talks to the patient on the phone. Or we're in a large group setting and I don't trust this corporate engine to be in my business or to know my schedule or to understand what I'm trying to do here today. Sure. So I'm going to put up barriers. I'm going to block my schedule. I'm going to make sure that every visit slot is pre-scheduled by appointment type, and we can't deviate from that because I don't trust them to manage my schedule. And so those are common things. And I'd like to say that I'm exaggerating them, but it really is almost that bad in a lot of places we go. So
that's right.
Some other things that really contribute to restrictive access. Patient populations are a real thing. Everyone says their patients are sicker and harder to manage than anyone else's, but there are certain areas that I've been where the no-show rates and cancellation rates are extremely high and or more challenging to address just because of the patient population and the makeup there. But no-shows and cancellations are a key piece of this, and how you manage that and where it falls on the priority list for the organization is something that data can really help with.
Well, that's one of those points too that goes back to the whole the link or the connection between more efficiency, improving patient access. So there's that operational efficiency, but there's also a clinical component to that as well, because I remember a number of years ago when they really first started talking about quality-based initiatives, quality-based reimbursement. That was really scary, and I think still is for a lot of providers out there, because so there are things they can't control as far as, particularly when you talk about clinical outcomes, but even on the front end, there's a lot of stuff that they can't control. So you're talking about population health and value-based reimbursement and things like that. The access is one of those things that they may not be able to control, but there are things that they can do to at least contribute to improve patient access and thus improve, ideally, the quality of the care process as a whole.
Right. And in some environments with population health models or capitated environments, the goal is not to have more visits, right? So we might not always be trying to amp the productivity, but you still want to have an efficient schedule, regardless of whether or not you're trying to see as many patients as possible, which many people are still incentivized around fee-for-service business. But we have seen places where you tailor the solution based on what you're trying to incentivize, and sometimes that's more nursing coordinators or better triage systems, so that you're not bringing people in unnecessarily. Yeah. The goal is not to keep people from no-showing or to keep people from canceling. That's going to happen no matter what. The goal is to set up a process and a system where even when people cancel and no-show, it has a minimal impact on the provider schedule or on those visit slots. And what you're really trying to avoid is not the no-show rate going down. That is important, but at the end of the day, the no-show rate can go up or down or stay the same. But if the doctor's schedules are full and they're not sitting idle throughout the day, then you're more efficient and more productive in most cases.
Yeah, that's a good distinction. I mean, because it's more than just addressing that basic issue of no-shows. Right,
and you can't fix it's the classic. You can't fix them if they won't let you. So the operational consistency, I think, especially with the growth in medical groups and this season of acquisition, is the other significant barrier. Most groups we work with have acquired providers or merged groups or something in the last 5 years, if not more recently. We're certainly seeing more additions than subtractions in provider numbers. And as the size of these groups grow, some are already big enough to warrant centralized resources and things of that nature. Some are moving that direction. Others don't need to and haven't. But either way, the variability from practice to practice, and particularly within practices, it's one thing for, large 20-man groups, to be in lockstep, but not to be coordinated between each other. But when it's a 3-man group and all 3 of the doctors are in completely different playing fields with regards to scheduling and access, then you've got to do something to bring consistency, or you're going to continue to shoot yourself in the foot, both with patients and with the providers.
Yeah. No, that was something I thought about before too, as we just started talking about this. But the amount of consolidation that we've seen, whether it's hospital physician alignment or just groups getting bigger and kind of going after that strength in numbers strategy, has got to be a major issue. We know there are a lot of operational issues as it relates to consolidation. And I think the interesting thing there is we do a lot of work as it relates to integration, and we do, and the transactions we work on, post-merger integration is a big deal. We've talked about it. I've presented on it. I've talked about it on the podcast before. Post-merger integration is much more about things like this than what you typically think of kind of in a traditional merger and acquisition scenario. And that's critical. And it's so easy for it to get lost in the mix or just pushed off and say, hey, we'll get to it eventually. And then next thing you know, 2 years after a acquisition or a merger occurred, you're still having disparate systems and processes and staffing and things like that. So that's huge. And if you're a hospital and you're talking about alignment there with a group, I think that can be even more challenging, just simply because a lot of hospitals aren't in the business of running medical practices, or they haven't been traditionally. And so it's a new thing, and it's easy to get wrong. So definitely a lot of opportunity there to gain some value. I definitely want to talk about how we can address patient access and kind of shoot for what kind of improvements and alternatives there are out there. Before that, though, let's just talk briefly why. I mean, I think on the surface it's kind of obvious, but I just, maybe talk for a minute about why is patient access such an issue that we really need to address?
Yeah, I do think it's relevant, and I also think it does seem to be pretty obvious in some cases. But as we already talked about, that easier, faster access to care as a patient is going to drive my satisfaction and build my loyalty to your organization, which at the end of the day is what every organization, big or small, health system or private practice, is trying to incentivize. Is we want patients who are loyal and want to be here, and we want them to be happy that they're here, as opposed to upset every time they come through the door. So for patients, I think it's and consumers in general, it's the right thing to do. For the hospital and health system, I think a lot of times this is seen as a patient service only issue, and we really view it as a revenue play as well. When you talk about patient access, people think about patient access complaints and people not getting in to see who they want. But what we're talked about already with better slot utilization, potentially increasing the number of available slots in many cases as you start to adjust schedules, reducing visit lengths, things like that. We've seen organizations reduce visit lengths and eliminate restrictions on schedules and immediately open up across their 100 doctor group 15,000 extra visit slots a year, where now if we're efficient in filling those slots, we're seeing meaningful revenue increase without ever asking a provider or a group to work harder or increase time, stay longer, come earlier. It can also, as we talked about, be a strategic play. Now we're seeing the competition ramp up around the consumerism, and as you use it as part of your strategy as a tool on the health system or provider group side, it can also help inform your other strategic decisions. You learn a lot about your operation when you start to peel this back. And we often start with patient access solutions, and by the time we're done, we're working on rev cycle and IT solutions and a lot of other things, because it's kind of a central hub for seeing how things come in and out of a provider practice. So I think for health systems, there's a significant incentive, and there's usually an investment to address it. But in our experience, that usually pays for itself in spades.
Sure. For
providers, I think a lot of times they feel like they're getting the squeeze on this because we're asking them to make the change, or to consider doing this as a group or things like that. But the happiest and most productive providers I know have a team around them that does this for them.
Yeah.
If the control has to be yours and you've got to manage it, then even if you're doing it well, it's not going to be something you like, because you're spending too much time on it. You're getting a lot of requests throughout the day, and you're going to miss visits.
I was going to say there are limitations naturally, regardless of how hard you want to work.
Yep, absolutely. And so that with taking them out of this and being more hands off with the management of their schedule, and allowing people to spend their time and energy filling your schedule instead, is a leap of faith for a lot of providers, especially if there's any distrust. I'm sure no one deals with that out in the world today, but sometimes providers don't trust the system or the corporate entity to support them. So,
but there's reason as to why they don't.
Absolutely.
So
absolutely,
I mean, that's valid.
Absolutely.
I feel like there could be a kind of another stakeholder in there as well that we've seen come on, or I've noticed in the last probably 5 to 10 years. But and think about the increased number of management services organizations, MSOs, that have come online here, and you kind of talked about, you alluded to it earlier in terms of particularly as groups get larger. and go to more, looking for those economies of scale by going through centralized services. I think it's interesting that a lot of people, a lot of groups even consider, if they hear the term MSO and they automatically assume basically rev cycle, billing and collections type function, your traditional kind of outsourced billing function that's managed centrally, central billing office type. But the MSOs that I've seen in the last couple of years are really able to address much more than just the billing and collections piece. And one of the big things I've seen them do, some of the better ones do very well, is the patient access piece. So it's the scheduling, it's the insurance verification, registration process, it's the technology, managing data, managing technology solutions, things like that. And then, the scale opportunity for growth for that group is, it increases significantly, but the efficiency of each individual provider also increases, just because they are able to give up that function and they're able to give it up to a resource that can cover all those different components and ideally hopefully do it well.
Yeah, I definitely think that at a certain size, it makes sense to centralize resources, just from a pure cost perspective. What we see, and I think that's an obvious choice for a lot of systems and leadership. What we see often, though, is we centralize before we've actually integrated, and so a lot of MSOs, and I'll even take it a step further, we see a lot of MSOs that are actually called, in this area, called patient contact centers or patient representatives or whatever it may be, which is completely separate, almost like your call center plus schedule management, more active schedule management. But when you bring this federation of practices into a centralized model, it's actually worse than just leaving it independent out there, because all you've done is integrate
a bunch of
more
bad
variability and bad practices. And now you've got these people sitting in an office somewhere that everyone calls to yell at, who can't do anything right on anyone's schedule because they don't know how, and there are too many rules. And even the two doctors they know sit in the hallway together don't do it the same way.
Right.
So,
well, it's the same. It's like with technology, for instance, just getting a technology solution like an EHR system or something like that isn't the answer. It's not going to be an automatic improvement. You got to have the systems and the processes behind it that ultimately make it work better.
Yeah. There's a lot of rebuilding the faith in a central contact center, or a centralized contact center, patient contact center, that we do with clients who have made that transition, and kind of fallen flat, and we get a lot of calls about, we did this, we think it's the right decision from an expense and resource perspective, but man, are we getting a lot of complaints from providers, patients, and staff about the
because after all, they're still services. A medical practice or a hospital is still a services business, so the systems behind those services have to work.
Yep.
You talk. One of the other things you kind of alluded to that I wanted to circle back on was the value piece and the impact that patient access could have from a bottom line perspective. Maybe just talk about that for a second, because I don't want to miss it.
Yeah, and this is something that when we talk about quantifying, the value of our work with clients, and trying to make sure they understand the return on their investment for pursuing solutions around patient access, it's difficult to tie, and we'll talk about this kind of in the fee-for-service environment only here for a minute. It's difficult to tie all wRVU increases, decreases, or visit increases and decreases to the patient access solutions you're putting in place. What I like to say is we're going to use a metric like wRVUs to track, and we want to see that go up, certainly. But we're also going to measure these things like third next available and visit slot utilization and the unbooked hours and things like that, so that we have a kind of a dashboard, whether it's a true dashboard or not, but at least a multi-point data set that can inform us about whether or not the work we're doing on patient access is actually driving the needle. But ultimately, a lot of people still get paid for seeing patients and generating wRVUs, and you want to see those numbers go up. And as I mentioned, there's a hard piece to that where we open up a lot of additional slots and we start filling them. Then that's good, right? Yeah. Revenue's going up, no one's staying any longer or later, and we've become more efficient in that regard. But the art of this is more in teaching people and putting in place the systems where now we've got a group and team supporting a provider that all has a vested interest in making sure that last minute cancellation, we had someone on deck ready to go, or we knew that something was going to happen. We're anticipating patient access. We're proactively calling. We put in place, for example, programs around chronic no-shows where we identify, just like you would a chronic disease state,
Sure.
we identify chronic no-shows, people with attendance problems across the system, whether they always no-show with me in my practice or if they no-show once with me, but turns out they've no-showed 5 other times with 5 other specialties within our network. And there are ways to do this in which you both communicate to the patients, and there's a patient education piece, and you start to manage those patients, flag them in your system, and manage them a little bit differently when you see them on the schedule. And again, the game is don't let patients and behavior you can't control drive your provider productivity. And so I think there's not a clean way to tie all of it, but there is a financial return is an important takeaway, which sometimes people question. And I think that there are multiple ways to get after it. And that's where I think, again, it's not a science, but more of an art of which levers do we pull with this specific situation to get the most bang for our buck.
Yeah, because I can see there are multiple data points here. There are multiple variables to this overall equation. They're not all perfectly or directly correlated, but I have to think that there's enough correlation in there. You start addressing some issues and making improvements on whether it's the no-shows or the time slotting or whatever it may be, you're going to see an impact downstream, some degree of correlation, whether it's on pure wRVUs, whether it's just on volume, whether it's obviously that's going to correlate to revenue in one way or another, but you can see some correlation there.
Yep, absolutely.
Yeah. All right, so let's talk about improving patient access then. I think this is kind of the bottom line of what we want to ultimately get to, because the idea here is that if every organization has to some degree a patient access challenge, issue, problem, whatever it may be, there are solutions out there. So maybe walk us through some of those.
Yeah, and I think for the sake of the listeners, instead of going too deep down any one of these paths, I'll kind of summarize several of the major areas that we've done a lot of work in. And when we get called in to assess an organization, whether about patient access or about everything else, these are some of the solutions that we've used successfully and things that we would look at to garner value. Some of these we've already mentioned, but in summary, again, engaging the physician leaders and getting buy-in, not after you've decided what needs to be done, but on the front end and constructing solutions. So if we're going to change the way provider schedules or visit links or appointment types are listed or managed or handled, there's no better starting point than having your physician leadership, whether it's formal leadership or volunteer physicians who have an interest, getting behind that and helping support those initiatives. Another one we've already talked about a little bit is enhancing provider scheduling efficiency by making more consistent criteria and protocols a part of each practice. And so reducing the variability is really what we're talking about there. But that will help. A third area is scheduling, better utilizing the resources you have to manage those provider schedules. So not only do we have to get the rules of the game right, the visit links, the appointment types, the scheduling templates, but we also have to set up our people and our systems in a way where we can effectively communicate about visits and manage in real time the patient issues. Another big one that is usually more of a problem than anyone thinks is this reducing of unbooked appointment slots and gaps on provider schedules. It's always shocking to see not only the amount, but also the type of blocks and holds on provider schedules. And I don't blame a doctor for wanting to play golf on a beautiful Thursday afternoon either. But there's a difference in one-offs and consistence. And, we see everything from every Thursday from 12 to 4, I'm blocked, or every Monday from, 10 to 2, I'm blocked for my long lunch and whatever it may be. And some of those are warranted and there's reasons to use blocks, but a lot of times a doctor will come out of a room and just say, "Hey, nurse or assistant, block my afternoon, or turns out I've got to go somewhere next Tuesday, cancel, move my entire day. And that happens a lot.
Yeah.
And some specialties are more notorious for it than others.
That's
right. That's a big one. And taking that out of the organization, and usually it's chronic offenders as well. It's not everyone, it's the few, but it usually makes a meaningful jump in productivity for some of those physicians. Another area that we often look at is the policy and process around practice closures. So some organizations have this under wraps and others don't, where a provider at any time can just say, hey, I'm not taking any new patients, or I don't have room for any more. And what does that mean? Is that my panel size? Is that because I have too long of a wait period? Or some providers maybe should be closed and aren't, and we don't have a tool to analyze that or to suggest it. And then if a provider says they want to close, we don't have any way to refute that because we don't have the data or policy around it. So practice closures are something that we often look at as well. Another area is around the increasing utilization of APPs and how they're used. Many organizations have added a lot of APPs. I don't necessarily disagree with adding them. I do think there's a right way to add them and probably a right number within each organization.
Sure.
But I certainly believe that once they're in, there needs to be pretty well-defined roles and responsibilities for how we're going to use them to get the most value. And that varies by specialty. It varies by care model. A lot of population health organizations are very successful in using APPs for a variety of things. But we often see the APP model where they go with a surgeon to the hospital and spend all day following around, and then my partner next door leaves them in the office seeing all the follow-ups and check-ins while I go do the surgeries. And there isn't necessarily a right or wrong, but you need a standard around it so that you're getting what you want out of your APPs. That's a resource you need to see the value of. And then the last one that I had on my list, we already talked about here recently, was the impact of no-shows and cancellations, which I've seen be the top priority and the lowest priority when we go in for patient access work. Usually, in either case, the data is usually flawed, and there's a misunderstanding about what their no-show and cancellation rates are, and then how much it's impacting the schedule. So getting your arms around it is worthwhile, regardless of whether it's a major issue or not.
Sure. Talking about the APP utilization, I think that's an interesting one, and it kind of ties into some of the other ones or some of the other things we've talked about as well, just because, that is one that I feel like is the variability, the variation out there in terms of utilization on APPs, it's all over the board. And that goes back to that whole scenario around as you grow larger, that consistency becomes much more important at that point as it relates to you individually, your individual physician or the group that's growing or consolidating, maybe how you're using those APPs is it's going to make a big impact, and it may be one of those things that needs to change. But any change like that directly, not only the physician in terms of how it affects the physician, but it also affects the patient. So that can be a key one to address, I would think.
Yep, absolutely. And when you go in and start to standardize or better understand, even if it's not standardized, the way you're using APPs, that you're going to use some data and information to put that together. And usually what we find is all of a sudden we're a lot better informed about whether we should or should not bring on APPs. And a lot of advanced practice providers were added because a doctor said they needed one. Yeah. If you give me an APP or an NP, I can do this much more. I'll be this much more productive. Sure. And some of them are right and some of them aren't. And again, there's natural variability by specialty. And so the effort is not to say an APP should be the same for everyone, but within each specialty or operating model, your care model really dictates a lot of this as well. There needs to be just a mutual understanding with the providers, physician and APP, and the employer of the health system.
One of the things that jumped out at me, again, this is a little bit of a tangent, but worked a number of years ago with a hospital that had employed a group of subspecialized surgeons, and we were looking at just some general production numbers, and they were through the roof, above 90th percentile levels. And then, so we said, well, what's the reasoning there? We went in and looked at some of the scheduling, and they were doing procedures on a Friday night at 10, 11 o'clock, sometimes later, a crazy number of procedures, and, office-based stuff. So not, it's not, doesn't maybe seem crazy on the surface, but when you start to look at some of these times, then you start talking to some of the staff. And you say, yeah, this person worked multiple times this month past midnight in the procedure room, maybe, and yeah, they got paid for it. But what's the sustainability of that, and what's the potential liability? And so anyway, that jumped out at me as one of these a potential scenario here where too much patient access was an issue. And obviously what they needed, well, not necessarily obviously, but on the surface, at least you can conclude one of the things they absolutely needed to do was they can't replicate one doctor, but you can try to extend what one doctor is able to do amongst multiple providers maybe, or go in and recruit additional providers. But, then you get to the bottom of that issue and there's control issues there. There's want to make sure they maintain their portion. And so there's some concern around dilution, things like that. But it was just interesting because you would think on the surface, those kind of types of numbers would be great and patient access must be solved for them. But it was actually kind of a reverse negative impact, I guess.
Yeah. I think with patient access, there are a lot of assumptions made that you understand the problem more than you do. And then wrapping your arms around how to make a change if you want to make a change, and what's going to drive the needle for you meaningfully, is difficult. And while it is, we refer to it as basic blocking and tackling, it's not simple. Mm-hmm. It's essential, not simple. Mm-hmm. And so I think that's where a lot of organizations just feel a little bit miffed and in some cases kind of shrug shoulders about these issues for a variety of reasons.
Yeah. That's good point. That's interesting. I guess in kind of bringing this full circle here, talk about, well, first let me say, and you alluded to it, but some of the solutions you walked through, I have to think there are kind of sub-components to many of those. So I know there's more to it than kind of what we were able to cover on the surface. And so that's one of those things where if there is someone out there that's comes across this and realizes one or more of those components, one of those points may be something that's a potential issue for them or their organization, we can absolutely drill down deeper on that. And I think we will in the future. Just talk for a minute as we kind of bring it full circle about monitoring patient access and some of the metrics around as you're thinking about improving what we can look for or what we can look at.
Yeah, I think we talked about some of these, but again, we'll list them kind of in summary here. One of the key metrics we like to use is third next available appointment, and some organizations monitor or report on this, and some don't. Many of the places that I've worked have to do it manually or choose to do it manually because the system either doesn't give them the information the way they want or doesn't give it to them at all.
Just out of curiosity, do you think more do or don't track that?
I think a lot of organizations at this point have tracked it at some point, and some have stopped because it was manual. It was too much work that they didn't do anything with, yeah, sure. Right? So it is a great measure of how long it's going to take to get in to see a provider. It's not, again, none of these stand on their own as your single patient access data point. Right. But for this one, I do think it's one of the most informed of how long is our line for this provider and how long is it really going to take to get in to see them. And we usually break that into like a short visit, long visit, might even do a physical or a consult as well. The problem with third next available data is we always want to aggregate it. And so if I'm a CEO of a health system, I want to see my total third next available. Yeah. And that's only helpful to a point because your third next available appointment could be 180 days and mine could be 3 days, and we're averaging out to something that still looks unattractive, but you're fine.
That's right. Yeah, that's right.
So I think the key with that is looking at it on the individual provider level when it comes to making decisions. You can aggregate for directional information, but it's tough to look at. Visit slot utilization is another one that we like to use. How many of those available appointments did we book? And there again, most EHRs can track that for you, but a lot of them have different definitions of it. And so going in and understanding what the data actually means. This is one that I think providers push back on when you tell them they're only utilizing 70% of their slots. That can be inflammatory, and it's often questioned. And so I think it's important just to understand what data you're getting, but usually that one's available with an EHR. The unbooked hours and slots, whether that's blocked or unavailable for some other reason, holds, all types of things that I've seen on provider schedules to prevent a visit from being put there. And when you tally that up, sometimes you realize, wow, if this is a 0.5 clinical FTE and they have this many unbooked hours, they're really only a 0.3 clinical FTE at the end of the day, sure, based on what we're expecting. As an aside on that, I think one of the key pieces of this, it's not really patient access, but operational, is defining your clinical FTE.
Yeah.
And that makes a big difference when you start to hold people accountable, which is why you want to have these metrics in the first place. The no-show and cancellation data I mentioned is usually available, but oftentimes misconstrued, garbage in, garbage out. You're relying on your front office staff in most cases to mark a patient a no-show or a cancellation, and if they haven't been trained or if they're not adhering to the training the same way, if the providers told them not to mark certain things a certain way, we often find that it's worse than we think or different than we think. We really also like to see inbound and outbound cancellations. How often are we canceling on the patient? One of the things when we talk about chronic no-shows is we're going to respect our visit slots more. We're not going to make you wait for 2 hours to see us. We're going to make sure that we honor the visit time. So we're not going to have that you showing up and doctor had to run to surgery and no one else can see you, all that kind of stuff. But in return, we want you to let us know at least 24 hours in advance, and we want you to be more accountable for the time that you've booked with us. So kind of placing more value on the visit. And again, that's the cultural and the art and of the operations that goes along with the data element. But no-shows and cancellations are an important one. Provider productivity, both with wRVUs and visit volumes. At the end of the day, that's going to be a primary concern for most providers, health systems, and groups. So pairing that with your access metrics, in my mind, is essential. And then the provider time away from practice, I mentioned, is kind of that true clinical FTE, whether it's vacation or other duties, administrative duties. Most of the places we go have inaccurate FTEs. A lot of providers now consider themselves to be a 1.0 FTE when they work 4 days a week, which may be okay if you have a certain number of patient contact hours, but we usually recommend boiling an FTE down to patient contact hours, and whether you have holds or blocks or not, what's your true FTE and what's stated. And that, again, is a pretty sensitive topic, so sometimes it's better to back into the FTE discussion with some of these other changes once you've kind of laid the groundwork for what's our impetus for change.
Sure.
Yeah, I think that, using these data points, as I mentioned, in concert, not to make the decisions for you, but to inform your leadership and then to actually use down the lines. I like to see front office staff with a dashboard who can in real time say, oh, look, this week, we only had 2 no-shows and we were averaging 30 before. Let's have a pizza party. Make it a game, make it an incentive for everyone, not just for a provider to be more productive. And that allows your management to focus on items other than patient complaints and things like that as well.
Yeah. Well, I think that's you said it right. And as far as the data goes, the garbage in, garbage out piece is huge. I mean, that's and it's the same thing here. I mean, a lot of these key performance indicators or metrics here, it's kind of like with everything else, or we're using benchmarks, right? There's typically more behind it, and I think the clinical FTE point is a great point because that's one of those where you can get skewed data. So someone may think they're doing really well in terms of percentiles on access, or maybe really poorly, but when you get down into it and really make the data comparable, then you realize you get a kind of accurate answer, or more accurate answer. And then the whole piece around making the information meaningful. Again, I think that's a big gap here in this process, because just because the data is available doesn't mean they're using it to do something with it. And even if they are doing something, are they doing something that's creating value? And I think there's a lot that can be done as far as that goes, as far as patient access goes, on is in terms of making that data meaningful and actionable. So this has been really helpful. And again, as we alluded to earlier, we're going to have more content on this. Obviously, Brandt will be available too. So if anybody has any questions on any of these points, particularly some of the solutions he went through or some of those KPIs or anything we talked about here, Brandt will obviously be available. We'll make sure his contact information is provided with the podcast episode, the information in the show notes. And then we'll talk about this, I know, more in the future as well. So we'll look forward to that. But until then, thanks for joining us, Brandt.
Thank you. I appreciate it.
And thanks everybody for listening. We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.